Everyone, good morning, good afternoon, good evening. Welcome to our Sci-Tech Asia 7th virtual seminar. This time we have three speakers bringing us the wonderful topic of histories of childbirth medicalization in East Asia and intercultural conversation. We're sorry that because of the technical issue of the link, we have to delay for like 10 minutes. So I think we will have also a 10 minutes delay in our Q&A session, just to make sure that that we could speak for kind of sufficient time with the speakers. So I'll first do a quick introduction of our three speakers. Gonzalo Santos, who is also the the founder of Sci-Tech Asia. He's an assistant professor of social cultural anthropology in the Department of Life Sciences and a full member of the Research Center for Anthropology and Health at the University of Coimbra. He's the author of Chinese Village Life Today, which is upcoming in 2021, and the co-editor of a collection called Transforming Patriarchy. And we have Suzanne Gottschang, who is a professor of anthropology at Smith College. She is the author of Formulas for Motherhood in a Chinese Hospital, published in 2018. Her research examines the intersection of gender, reproductive technologies, public health, science, and policy. Her current projects include science, technology, and modernity in East Asia, technologies of infant formula, traditional Chinese veterinary medicine in the United States and China. And we have Chiaki Shirai, who is a professor of sociology in the Department of Social and Human Studies at Shizuoka University. She is the author of History of Childbirth, Childbearing, and Midwifery in Japan, published in 2016. And her research experience and expertise is in family sociology. And she is currently working on two projects. One is the Gender and Reproduction in Modern Asia International Comparison, and Prenatal Testing and Disability in Modern Asia International Comparison. So let's welcome the three speakers, and I'm very excited, and I think you as well, to hear what they're going to bring us today. So I will leave the stage to them.
Hello, everyone. Thank you, Yi-chan, for your very kind introduction. And apologies once again to the participants for this delay. Anyway, I'm very delighted to be here with my colleagues, Suzanne and Chiaki. For us, this is truly a celebration in many ways. We are going to talk to you about a special issue that we published with the journal Technology and Culture, published by the Society for the History of Technology last year in April 2020. That was a bit of an achievement to publish this special issue. An achievement not only in the sense that it took quite a long time to get it published, but that in journals of science and technology studies, despite a large and growing body of feminist scholarship on reproduction, it's rarely the case that we talk about reproduction in specialized journals on science and technology. I mean, in general, to be honest, childbirth is rarely in the news. Big projects, big engineering projects in general tend to get a lot of attention. Big political, big changes or changes in big public policies tend to get sort of all the attention, the market, the economy. These are the topics that tend to capture the minds of the media and its audiences. We're trying to kind of counter a little bit that, and inspired by a growing body of feminist scholarship, as I mentioned, we're trying to place reproduction at the center of society, really, and by extension, at the center of social theory. We're particularly inspired by a growing body of literature on new reproductive technologies because we're concerned with the relationship between technology and society, between technology and morality. And we feel that literature on in vitro fertilization, on surrogacy, and so on and so forth, played a central role in not just drawing attention to the importance of reproduction, but also talking about the technological dimensions of reproduction and how changes in technology also create sort of new moral dilemmas in society. But one of the effects of this research on new RTs, on new reproductive technologies, is that it tends to highlight the significance of the latest technologies. So it really is important when it comes to reproductive technologies to talk about the latest ones, the most innovative ones, the ones that are really changing and supposedly completely transforming society. And the side effect of that is that we kind of tend to neglect the study of more mundane, not so new technologies that yet are widely disseminated in society and are causing all kinds of effects and all kinds of moral reflections and tensions in society. So we're kind of saying that we're kind of calling for a focus on more mundane forms, on more mundane reproductive technology, and more specifically on more mundane forms of childbirth technologies or medicalized technology. And by doing that, we're kind of making also a contribution to that sort of reproductive technology literature in the sense that we're developing a less innovation-centric notion of reproductive technologies. There's, of course, a growing or very large body of literature, feminist scholarship on childbirth medicalization. I'm not going to go into that in detail. Let me just say that, this literature is both historical, sociological, and anthropological. It has focused on how the rise of scientific medicine from the 18th century onwards as a strong social institution of control, initiated a gradual process of medical modernization of birth that started to intensify its global reach during the 20th century. I mean, for example, Judy Weissman, techno-feminist, has wonderful chapters on that. From the 1980s onwards, anthropology and sociology start to talk about the rise of a global model of technocratic birth. So, for example, Roby, Davis, Floyd, and Kosminski. So it's as if we went from too little, too late usage of medical technologies, too much, too soon. And feminists have been criticizing excessive medicalization and talking about the dangers of obstetric violence. Research, of course, is not circumscribed to European and American experience, but remains largely centered on Western trajectories and discourses. We're kind of calling for the usage of East Asia as a method here. We feel that expanding the field of comparison to East Asia and joining the group of scholarships in East Asia that are starting to work on reproductive technology, we can do two things that are very useful when it comes to reproduction theory. One is to highlight the continuing importance of indigenous medical traditions in the process of childbirth management, a topic that is completely ignored in studies of Euro-American traditions. It's as if there are no alternative forms of medicine other than scientific medicine. And two, we're trying to question the limitations of Western-centric discourses and models based on assumptions of liberal individualism. We're looking at China and Japan. And of course, they pose a challenge of comparison because on many levels, as we will see in the presentations, they have very different trajectories and timings of childbirth medicalization, but they also have converging features. One is that in both, it's clear that indigenous medical traditions continue to have a very important role. And two, the idea that, childbirth, the notion that childbirth experiences should be a matter of individual choice has very limited social currency in these two contexts. So in the special section, we talk of a moral double bind that sort of characterizes and converges the birthing systems of these two countries. One that is shaped by two competing priorities. On the one hand, we find a drive towards the technocratic medicalization of births for the sake of safety and risk management, and on the other hand, the drive to be more natural and avoid unnecessary medical interventions. This moral double bind poses, of course, seemingly irreconcilable demands on pregnant women, but it's also very flexible at the same time, so that we can be, we can go for medicalization and at the same time conceptualize that as natural. So I would like to now move on to the discussion of each individual case. So I would like to invite Chiaki Shirai to introduce us to the Japanese case, please. Chiaki Shirai?
Hi. Me? It's
Yeah.
my turn?
Yeah.
Oh, sorry. So, nice to meet you, everyone. I'm Chiaki Shirai. Um, in my presentation, this paper explores the um, changing institutional and technological frameworks of childbirth practice in Japan, highlighting the historical dynamism and the normative dimensions of women's experience. This paper shows how childbirth in Japan was subject to a very powerful and reacting process of medicalization going back to the mid-19th century. In present-day Japan, the drive towards high-tech medicalization remains strong, but there is also an emphasis on the need to be natural and healthy and to avoid unnecessary medical interventions in the body. These two seemingly contradictory sets of demands are an important feature of contemporary Japanese society. Their coexistence is only possible due to the continuing hold of a system of moral responsibility that emphasizes the duty of mothers to do whatever is necessary in terms of medical care to protect the safety and the well-being of their bodies. In fact, there are some turning points from pre-modern to modern, but in this paper, we will examine three modern turning points. The modern turning point in the history of childbirth in Japan can be divided into three categories. One is the Meiji era to post-World War II. Second is the period from the 1970s to the 1990s. Third is the period from the turn of the millennium to the present. A woman always carries powerful normative perceptions of being a good mother. On the one hand, there is a strong emphasis on a model of natural pregnancy and childbirth that build on the idea that mothers should avoid medical interventions as much as possible. On the other hand, there is also a strong emphasis on the virtues of a highly medicalized model of pregnancy and childbirth that stipulates that mothers have a moral responsibility to make sure that their fetus receives proper institutional medical care. The construction of this double-bind model of childbirth and motherhood was shaped by a threefold process of institutionalization and medicalization and professionalization. In the Meiji era to post-World War II, the legalization, institutionalization, and qualification, 資格化 in Japanese, of midwifery resulted in the professionalization of the role of samba. Samba is direct entry midwives with national certification progressed. Long-standing state supervision of midwifery may help explain how midwives played an important role in propagating modern concepts of hygiene and medicine throughout Japan. By the first decades of the 20th century, midwives were providing care and assistance to a large share of home deliveries in Japan. This is a graph showing the trends in birth attendance and place of birth. In 1945, the white part you can see is home birth. The birth attendant was almost always a midwife. Between 1960s and 1965, birth attendants shifted from midwives to doctors, and place of birth shifted from homes to medical facilities. The period from the 1970s to the 1990s, the medicalization of childbirth was criticized for leading an increase in medical accidents, especially accidents during labor induction, and a number of instances of medical malpractice came to public awareness. By the 1990s, new possibilities for how women childbirth arose with the formation of organizations and networks that promoted natural birth, active birth, and freestyle childbirth, and so on. But one of the distinctive features of Japan's natural childbirth movement is that it never really pushed for the demedicalization of childbirth, as was the case in much of Western Europe and North America. I will skip some slides. Sorry. As mentioned earlier, the first of the contemporary normative dilemma is a norm called good mothers. The biomedicalization of pregnancy and childbirth has led to characterizing women who don't attend prenatal checkups or those who don't maintain their own health as perpetrators of fetal abuse, in Japanese, 胎児虐待. I heard the other day that a pregnant woman who had undergone a prenatal checkup to make sure she was healthy tried to give birth alone at home, and her newborn baby was taken into custody by the child guidance center and not returned to her. The reason is that this is equivalent to medical neglect. Is it the same in your country? When the parents don't allow their child to receive necessary medical treatment, this is termed medical neglect. As noted by an obstetrician and gynecologist quoted in the above-mentioned Sankei Shimbun newspaper article entitled "No Prenatal Care is Fetal Abuse." It is feeder abuse not to undergo prenatal checkups when there are coupons for prenatal checkups. Pregnant women who engage in feeder abuse are at higher risk of engaging in child abuse, this article says. And natural childbirth is viewed as something that should be carried out under the guidance of a health professional, even if someone else, such as a partner, assists the birth at home. It is called non-assisted childbirth, mukaijo shussan in Japanese, and is considered a form of egoism, reflective of a consumer society that exposes the fetus to danger for the purpose of the self-fulfillment of parents. And the second contemporary normative dilemma is a norm called natural body. This is very, very old newspaper in 1918. It is in 1918. This newspaper says, it is not good to give birth while you don't notice. Don't stop painless labor. No, sorry. Stop painless labor. This paper says in 1918. This paper also very old in 1975. This newspaper says scheduled labor, pitfalls for artificial labor. And in Japan, Caesarean sections is very low. And sorry. Women always carry powerful normative perceptions of being a good mother. I said, as mentioned earlier. And in this way, there is a double bind of keeping a natural body while accepting medical care and technologies emerged. What do you think of this? Please share your thoughts and opinions with us. Thank you very much for your attention. Thank you. And I would appreciate it if you could write your questions and comments in the chat or Q&A. Thank you so much.
Thank you, Chiaki Shirai. Suzanne, please, the floor is yours.
Hello, everyone. Good morning. I want to thank Gonzalo and everyone at Sci-Tech Asia for arranging for this webinar. It's a pleasure to talk about this work and this project. As Gonzalo said, it was a long time coming, and we're very excited to talk about it here. So I'm going to talk about maternal mortality, midwives, and C-sections in China from the 1900s to the 2000s. Oh, okay, hold on. All right. So in 2010, news reports were circulating around the world that the deaths of mothers in childbirth had decreased globally by more than 40% since 1990. And this was part of a United Nations Millennium Development Project to reduce the world's maternal mortality by doing things like increasing hospital births and changing the healthcare system and the access to healthcare that women had around the world. However, China was one of, I think, 6 countries that actually achieved this goal. So I wanted to talk a little bit about what maternal mortality is and how it's defined before I turn to the 3 periods of time in China's modern history that I'm going to talk about. So it's defined as the number of deaths of women within 42 days of pregnancy. And it's the ratio deaths per 100,000 women. There are 2 types of maternal mortality related to pregnancy and delivery. And then there's the direct one. And then the indirect one is conditions of the mother that may be exacerbated by pregnancy. And I'm going to focus primarily on the first one, the direct causes. And you'll notice that these are things like bleeding, abortion complications, hypertension, and blood clots. This is important in understanding how maternal mortality works in countries. So one of the reasons that I think maternal mortality is an interesting thing to look at is that, vital statistics have long been associated with modernity, and maternal mortality is generally accepted as a measure of how effective and accessible a healthcare system is for a nation. The problem is that the conditions that may cause a maternal death are not present prior to their appearance. They require immediate assistance or emergency care and technology and skilled medical care. Things like blood, drugs, trained medical personnel, and transport are essential. So unlike infant mortality, which can be improved greatly through women having good prenatal care, maternal mortality is not something that can be anticipated necessarily. And this is a framework that was designed to sort of show that there are all of these reasons that people delay getting that care. And they include socioeconomic cultural factors about whether one should, availability of facilities, and then the quality of care. A lot of times people resist hospitals because they don't anticipate getting good care on them. So I'm going to talk about the 3 periods where we see dramatic changes in China's maternal mortality rates and the things that they were doing. Friedrich Andrews coined this idea of the sick woman of Asia because maternal mortality rates were quite high. In the 1920s, about 1,500 per 100,000. Most women prior to the 20s gave birth with a lay midwife or a family member at home. But this started to change in this era as more urban women, in particular elite urban women, started demanding professional care. So there were popular articles that authors wrote comparing China with Japan. One showed that in 1915, Japan had 135 midwifery schools, and in the 20s, China only had a handful. So as a result of that, those observations, China started to began to create professional midwife programs in the 20s and 30s. There weren't a lot, and they didn't make a huge difference, although they did in Beijing. I can talk about that later if we have time. But in the early years of the CCP, they inherited this high death rate, but they had decreased it by about 150 to 100,000 deaths in the early 1960s, which is quite significant. They did this by increasing the training of midwives, and they did this with both professional midwives, and in other words, they had midwifery schools, but they also retrained lay midwives as well. They also increased the numbers of hospitals and clinics, so that by 1990, 70% of urban women were giving birth in hospitals, 60% of rural women were giving birth in hospitals. And this is ahead of the WHO's efforts to improve maternal mortality globally, as we will see. I'm going really fast, but I want to leave time for discussion. So post-reform China, though, brings around some interesting problems. So C-section rates, especially in these earlier periods, are very low. By the time we get to the market reforms, birth planning policy, and hospitals' relationship with the state changes, we see some big differences. So first of all, the market reforms, most of us are aware of those, but the birth planning policy is a really interesting one because it automatically reduces maternal mortality. Women are having fewer babies. And in fact, the technologies around reducing maternal mortality are not things like hospitals, but rather pregnancy prevention. And then hospitals in the late 80s, early 90s the state started to withdraw their funding and support of these hospital medical care. So, and I'll talk about the consequences of that in just a minute. So some of the things that happened is that there were some really problematic changes in the as a result of the healthcare reforms, and increased, I mean, all of the vital statistics in China started to look not so good because people did not have good access to healthcare. They lost their healthcare insurance. Hospitals were charging more. And of course, they needed to make money, these hospitals. So they also started increasing, we see an increase with C-sections around this time as well. In the 1990s, China realized it needed to change things. So they implemented a form of maternity insurance to ensure that women who were poor, who needed hospitals, could get assistance paying for them. They also became an increasingly important collaborator with WHO and UNICEF programs and policies, including this 1995 law on the protection of mothers and infants. This comes out of some WHO UNICEF initiatives. 1998, we see the World Bank and the CCP are focusing on rural healthcare. And in this time, in rural China, we see a dramatic increase in hospital births from 20% in 1998 to 70% in 2006. Importantly, the state also abolishes midwifery and closes midwifery schools and increases the training of physicians. So immediately we're seeing this change to, when we talk about medicalizing childbirth, we're seeing this very significant change because midwives, of course, tend not to be very interventionist, and generally physicians who are trained in obstetrics, that is, their mode of care. So what are the consequences of bringing normal births into the purview of hospitals and physicians? And many of us are aware, well, China was very successful in reducing maternal mortality. They did it by making sure, or the goal is that every woman will give birth in a medical facility. They also provided what they called a facility birth subsidy in rural areas, so that by 2011, 90% of all births are in hospitals. Maternal mortality rates are affected in that they decline from 59 per 100,000 in 2000 to 36 in 2000, I think that was 2011. So what are the technical consequences? Well, many of us have heard about the cesarean section rate in China. In some places, it's been up to 80% in urban hospitals. But I think there are other interesting uses of technology that are a consequence of this new way of giving birth. And that is that we see things like an increased use of ultrasound scans. These are, pretty routine in the US, or in the West in many cases. But we see that they dramatically increase because hospitals all over the country have access to them, and therefore women do. We also know that women are often using these to determine the sex of the child, even though it's technically illegal. But what some studies have found is that women who have more than 2 ultrasound scans before birth often are more likely, almost 2 times more likely to have a C-section than those who don't have as many, who don't have more than 1 scan. So I think this is a really interesting, sort of different kind of technological consequence than we might think about in relationship to hospitalized births. So the future of maternal mortality in China is going to be affected by some other policy and technology changes. One is the relaxation of the birth planning policy. Remember that having only 1 child dramatically reduced maternal mortality in China. It will, as women increasingly have more children, it will go up. And we're also seeing that Chinese women are not having children as young as they used to. So increased maternal age always increases risk of maternal mortality. And of course, we see increased rates of cesarean section. So I want to turn this over to Gonçalo. I really appreciate your listening, and I'm looking forward to our discussion.
Thank you very much, Suzanne. Can you see my screen? Yeah.
Mm-hmm. Yep.
Okay. So I'm going to complement a little bit what my colleague Suzanne about the changing realities of childbirth in China by taking you on a trip to rural China. I become sort of interested in childbirth in the context of longitudinal fieldwork in rural areas. In case you're wondering, that's me between these two red circles, which I had to put to protect the privacy of my informants. And that's in 1999. That's when I first arrived in village China, and that's like 12 years later with the same family, the same kids in yellow dots, but they are no longer 5 and 7. They are grown-ups and married with kids. It's been remarkable to kind of witness the transformations over 2 decades in this part of village China. When I first arrived in the 90s, home births still dominated, attended by village midwives. And quite often these births took place in secret locations because people wanted to escape official birth planning regulations. Very low rates of medical assisted hospital births back then. After the 2000s, at the turn of the millennium, I started to witness a shift to universal hospital births. And at the same time, a shift towards an increasingly medicalized and technologized model of birth. Childbirth became managed as a cascade of obstetric interventions, to use the celebrated term in feminist scholarship, and rising rates of Caesarean births between 2010 and 2018, 40%. These transformations at the sort of micro level echo a larger childbirth revolution that really goes back a long way in time, up until the early 20th century, the dominant model of birth in China was sort of non-interventionist based on Chinese medical theories. And the first national program promoting the medical modernization of birth, and so engagement with scientific medicine, was in the early 20th century. By the Maoist period, we had an expanded program of medical modernization, combining high-tech, so hospitals, with low-tech community health workers, with significant distinctions between rural and urban areas. By the reform period after 1978, we get to the period that Suzanne was talking about, and that's a state-led shift to universal hospital births. It all started with the birth planning policy, I've already mentioned it, that helped promote hospital births. But still, in 1988, hospital birth rates in China was still below 50%. From the 1990s onwards, as Suzanne described, we started to have a much more aggressive mandatory hospital birth policy, and the requirement that obstetric professionals should be present. And the target was reached, indeed. By the early 2000s, over 90% of hospital births were recorded. But there was one unforeseen effect. And this is that the shift to the hospital went hand in hand with the rise of a highly interventional model of births with high rates of cesareans. The surge in cesarean started in urban areas in the 90s, but it then expanded to the rural areas after the 2000s. In 1993, cesarean rate in China was 4.9, which is very low. Medical doctors say it's a typical developing country sort of rate. By 2002, it was 20.4. And between 2004 and 2008, a famous study by WHO sounded the alarm. China had 46% rate of cesarean, well above the 10.15% levels recommended by the World Health Organization. The government responded with new policies to curb cesarean rates, but the effects were not very significant, at least statistically. The latest numbers point to an average of 32.7% between 2008 and 2014. And another statistic points to levels above 30% between 2012 and 2018. With a colleague of mine, anthropologist Jun Jiang, who is probably present, she has collected a wonderful sample of over 30,000 deliveries of a major hospital in Guangzhou. And as you can see in the blue line here, I mean, average rates of cesarean section are close to 40% in 2017. The Chinese case, of course, has its peculiarities. I mean, there is a global trend to rising cesarean rates, and China is amongst the countries in the world with the highest C-section rates in the world. But the surge in cesarean rates in China was particularly sharp and particularly fast. You know, as you can see in the green line here, this is the line for the United States. The surge started in the 60s, very gradually. And by the late 80s, it started to increase again. In the case of China, the surge really begins in the 90s, and it's really very fast and steady and sharp. I was interested as an ethnographer doing fieldwork in rural areas about the moral dimensions of the routinization of cesarean deliveries. I mean, there's a large literature in anthropology, sociology, showing how reproductive technologies are sites for the production of gender ethical subjectivities. Francesca Bray, for example, Judy Wiseman. I was interested in asking the question of what kinds of moral tensions are emerging amongst ordinary women in rural China regarding ongoing processes of routinization of cesarean deliveries. Do these tensions in particular have an important generational component given the speed and the compressed nature of the changes? Birth wars are all over the world. Cesarean birth is highly divisive. In countries like the United States, for example, the rise of cesarean births has led to a counter movement that sort of, criticized the medical establishment, and at the same time called for a return to sort of more natural kind of arrangements, either home births or else hospital births with limited or no medical intervention whatsoever. But in the U.S. case, these divisions between supporters of more natural forms of birth and supporters of more medicalized forms of birth are largely conceptualized as a matter of individual choice. In China, we have similar kinds of tensions. I mean, in the sense that, by and large, giving birth in the hospital under medical guidance is considered to be the safest option. But there are also profound disagreements regarding the value of cesareans. Most women endorse official guidelines recommending the practice of vaginal delivery, but many young women, of course, are favoring cesarean births. At the same time, there are growing concerns over the potential hazards of rising cesarean birth rates. But two things are crucial in these concerns, is that they do not involve a radical critique of the authority of the medical establishment that would be tantamount to criticizing the Communist Party. And of course, the issue of having a cesarean or not is not framed as a matter of individual choice. I first started to notice this issue when I started collecting childbirth stories, which I did over the years. I'm going to give you one example of a birthing stories. I could have selected another one. This is the story of Lisa, who was born in the late 80s, got married in the late 2000s. And this is the story of the birth of her first son. She was in the market town in the countryside, and in the morning she started to have contractions September 15th, 2012. At 2 p.m. she went to the local rural clinic accompanied by her mother-in-law and the mother of this last one, an experienced village midwife. Lisa was checked by the doctor at around 3 p.m. and in less than 15 minutes the doctor leaves the room and goes to talk with the mother-in-law, recommending an emergency cesarean, saying that the cervix was not sufficiently dilated, the girl was too weak to go through the pain of natural birth, and so she urged the mother-in-law to sign the consent form and agree the payment. The mother-in-law was not very happy with the cesarean recommendation, so she started to to urge her mother or a midwife to kind of question the doctor, which she did because she's particularly strong-willed, this village midwife. So she questioned the doctor on the necessity of the Cesarean section, saying, "Doctor, I'm 62 years old. I have 6 children myself, and I have assisted the delivery of many babies. I never met a woman who gave birth without pain. This girl is young, well-built, and eats well. The fetus is in the right position, and everything else seems fine. Why does she need to be cut open?" Anyway, the doctor was outraged and said that he would not take any responsibility if anything goes wrong during vaginal delivery, but he ended up doing it. And the baby was born naturally at 5 p.m. Anyway, I'm telling you this story because I want to make the point that birthing experiences are more usefully conceptualized as collective processes of negotiation. In the Chinese case, these collective processes of negotiation work around the triangle between hospital or doctor, the pregnant woman, and the family. And this is explicitly, this can be explicitly seen in the way that, cesarean section consent forms have to be signed by family members, not just the pregnant woman. I'm interested in this lower part of the triangle. So I'm interested in putting forward a woman-centered approach and looking at gynocentric, what I call gynocentric networks of care. Because the shift to hospital births, did not put an end to the continuing importance of women's gynocentric networks of maternity care and childbirth support. That's why when Lisa went to the hospital, she was not alone, and she was not with her husband at all. She was with her mother-in-law, and with her the mother of the mother-in-law, which are the female relative, the experienced female relatives that accompany her during her daily family life in this part of rural Guangdong. In fact, in most rural areas, or in many rural areas, experienced female relatives like mothers-in-law continue to be the main source of personal advice on childbirth matters. This means that young women's childbirth experience and their attitudes to cesarean deliveries are being mediated by these gendered intergenerational conversations. So I've been sort of interviewing over the years village mothers from different generations, collecting birth stories and their views on the routinization of cesarean deliveries. This is a photo, again, with the usual circles to hide the privacy and safety of my interlocutors, of an interview section, focus group. I organize focus groups with women from the same generation to debate childbirth matters. This is the photo of a focus session with village mothers born in the 40s and 50s, so with their birthing experience in the late 60s, 70s, and 80s, so mostly home births. I focus on 2 different generations in particular. The older generation, so this is the generation of the midwife that interfered with the decision of the doctor, and this generation was born in the Mao era, had 4 or more children, was the last to experience low-tech births at home. And the younger generation, that's the generation of Lisa, born in the Reform era, had 2 or 3 children, and was the first to give birth in the hospital under increasingly medicalized and technologized procedures. I found, of course, needless to say, significant generational differences. I mean, the differences were not just about the fact that they had very different experiences of birth. I mean, home births assisted by village midwives, and hospital births with access mediated by obstetric professionals, with very high rates of all kinds of surgical interventions, from episiotomy to also cesarean surgery. It was also the case that we had very different generational frameworks of techno-moral evaluation of what counts as a good birth, including, different evaluations of the recent trend towards high rates of cesarean section. For the younger generation, all mothers say that childbirth is dangerous and must be managed by obstetric professionals, but they continue to emphasize the importance of traditional ideologies celebrating the virtues of vaginal delivery. Most mothers of this generation say that cesarean deliveries should only be performed under emergency conditions, but there are disagreements over what counts as an emergency situation. At least 40% of my sample of younger mothers interviewed had cesarean delivery. None of these cesareans was pre-scheduled, as it's usually the case in rural areas, in contrast to middle-class urban mothers who have cesarean. Most of these cesareans involved a request from the mother, but for different reasons. Okay, one reason that commonly popped up: inability to cope with the pain. It's too painful. I couldn't take it anymore. Perception that vaginal deliveries involve significant risks for newborns. And this was something often told by doctors. You know, the shape of the pelvis is too small for the size of the feet. Concerns with bodily shape, including the shape of the pelvis and the uterus of the mother. And of course, desire to stay in the hospital longer to get some rest from family duties, to get a break from mother-in-law, for example. Older generation. Well, scientific medicine is good. It helped women give birth more safely, but the recent trend towards excessive medical supervision is not good. Young women are becoming too soft. And this is a quote: if we could deliver babies at home without any medical assistance, why can't the younger generation handle a vaginal delivery in the safety of the hospital? They also say that women, they look at women not as vulnerable beings. They look at women as strong and having the capacity to endure the pain of birth through self-reliance. They also have strong concerns with the well-being of the family. Cesareans are too costly and place an unnecessary economic burden on the family. Very suspicious of medical doctors. They say that most medical doctors are greedy and self-interested. These contrasting moral views point to a more general moral double bind. So on the one hand, we see there's a drive towards the, being close to the doctors, being in the hospital, protect the safety of the baby, manage risks. But at the same time, there's an emphasis on we have to be natural because, having a vaginal delivery is better. And, we should also try to avoid unnecessary medical intervention. So this moral double bind seems to place irreconcilable demands on pregnant women, but it allows for some flexibility. That's why you have, some women who are having a highly medicalized vaginal delivery and yet looking at it as a natural experience. So we thus see how ideals of childbirth are changing from the perspective of women. I mean, the traditional ethical system, largely derived from indigenous non-interventionist medical conceptualizations of birth, was also shaped by socialist ideologies of work and endurance. The idea that a good mother has to be able to endure the pain of vaginal delivery. But then we also have an emerging ethical system here. A good mother should try to endure the pain of natural birth, but only if there are no biomedical risks involved for the baby and the mother. Having the moral responsibility to handle birth is too burdensome. Better to delegate the responsibility to the medical doctor. Birth is not about medical safety. There are other considerations: level of pain and physical hardship, health risks for mother and infant, impact on bodily shape of mother. The traditional ethical system, as you can see, is being transformed, but it has not disappeared. Traditional socialist ideology is particularly strong in the countryside. There's this idea that rural women are tough. This is a quote that I often heard so many times, told by different women, quite often women who had C-section. Quote, rural women only have C-sections after trying to give birth naturally for a long period of time. Not unlike urban women who plan to have a C-section from earlier on because they are soft, of course. Thank you very much.
Thank you, Gonzalo. You could now drop down the screen so we can see each other. And anybody has any question, please send it to the chat box or just raise hand so I could call upon you to speak up. Yeah, if not, I'll just take use of the gap to ask my question first. So I've been hearing a lot about, the social expectations of being a good mother in those stories, and also the massive pressures of, for example, mortality and the painfulness of going through C-section. So this makes me wonder. So during this medicalization of childbirth in China, is there any discourse of mental health that is also going on there that maybe caters to the individuality of the woman, from another way? Because, for example, the pregnancy-related depression is something that is of a heated topic in China, as far as I know, because I, was trained as a counselor before. And then also people were talking about things like, the C-section's influence on the development of the child's brain and things like that. So I think they sounds like some kind of a more individualized discourse of thinking about the individual psyche, or kind of individualized development of people, and also related to, for example, what Chiaki Shirai says about the sense of responsibility of being a good mother. I think that could also cause shame and pressures on the woman, which is also related to things like depression and kind of a mother's mental health.
Suzanne, do you want to go? Do you want to answer, or?
Yeah, I mean, I think that you raised some really important points, and I think that I think thinking about these non-technological consequences is actually a really important thing that actually I think hasn't been, it has been done in other places, but I think it's something we're still missing in our understanding of how birth shapes individual experience. I think Gonzalo's work gives us some really important ideas about it. But yeah, postpartum depression is something that's relatively recently become something that people are talking about in China. Before that, it quote didn't exist. So I think these are really important consequences that step us outside of the traditional kind of birthing technologies, but also then require new technologies to manage. For example, antidepressants or other kinds of things. So I see these as chains of things that kind of start to cascade from this particular moment for individuals, but then also for the nation itself.
Can I just say something else very, very quickly? I see two possible ways of answering your question, Ichan, if I understood it correctly. I mean, one way is it's the medicalized answer. Again, we go to the moral, to the moral double bind that we were talking about. The medicalized answer is you are not a good mother and you're not taking proper care of yourself and your child if you're not following all the prescriptions that are lined up in the obstetric script, basically. And so you are vulnerable also to be accused of, to use the Japanese term, fetal abuse, right? So you're being a bad mother because you're not following the scripts of what doctors are telling you, what the hospital is telling you. Even though many of the requests being made in the case of China is certainly true, prenatal checkups have become completely inflated. It's just an overwhelming amount of prenatal checkups with very few explanations in many cases, right? But there's also an alternative answer to your question, which is, a sort of a more recent phenomenon, I would say, in China, and it's the rise of a wellness culture. The rise of a wellness culture amongst pregnant women and mothers to be in general, a concern with not buying blindly into medicalized models, but trying to make a more in-depth assessment of what is best for their children. on the basis of both internationally circulating models of well-being for mothers, or in some cases also relying on indigenous medical traditions. So I think this is also new, and it's bound to keep on growing, but it's not yet translating in overt public challenges to the medical establishment. Yeah.
Thank you. Yeah, maybe let's move on to other people's question in the chat box.
So can I answer
yeah.
one? Okay, so to Maria João Neves, yes, in rural China, the notion of the one-child policy was very misleading. The one-child rule really applied to, when it applied, because now it's a two-child policy, but when it applied up until 2015-16, was a rule that was really circumscribed to major urban areas and also to some rural areas. In much of rural China, people had, even amongst the Han Chinese population, people had more than one child. Yeah. And also for Junko Zhao, if I may respond. Yeah. Yeah, I really liked your point. But I would like to also add a twist. I mean, I totally agree with you. I think the authority, both of, on the one hand, the family relatives, mothers-in-law, husbands, mothers in some cases, on the one hand, and on the other hand, then the medical workers. I think it's truly the I think it's the predicament of pregnant women in most of East Asia. But at the same time, I mean, there's a dark side to it and there's a positive side to it, right? I mean, the positive side to it is that, you know, you can look at it as a form of care. I mean, when it works, when it fully works, when mothers-in-law are truly caring for their daughters-in-law, when medical doctors are truly caring for their patients, you know, it can work as something positive. Yeah, I don't know if you wanted to respond.
Junko, you could. I mean, yes.
Yeah, can I say something? So yes, so I agree. When system works, probably the woman will get a good result and then they might be happy. But I think the main point is decision is made by somebody else other than women. So that is really, birth can be very empowering experience for women. But if the care is good, therefore women get the good result, there is not so much empowering part of the birth that she is still done rather than she's done it.
I mean, I would say yes, but I think that the way you're conceptualizing is, for you, empowerment seems to be individual empowerment. And I'm not sure, I am not sure if for Lisa, for example, and I interviewed her many times, right? I interviewed Lisa many times after what happened, right? And I thought that she would kind of come to me and say, I'm actually really furious with my mother-in-law and my mother and her mother, because I actually wanted to have a C-section. I couldn't take it anymore. And that's not what she told me. You know, on several occasions, I felt that actually she appreciated what happened, and she took that as just a form of care, because she sees herself as a piece in a larger whole, right? In a more relational arrangement. Okay.
Can I just say, you know, the natural birth and then birth, any birth, I think, if you think about natural birth in the empowering for individual, probably yes, I'm talking about individual experience, but what I mean is that the women make decision of either intervene, you know, to choose to have, let's say, epidural, that is intervention, but that is to have the decision respected is empowering. so or if somebody wants to have a cesarean section, and then she thought about it, she got the information, and then she made a decision, and then to have that decision respected probably is as
empowering.
Yes, as you know, it is decision she makes about her body.
Right.
Yes, and then it's probably still the individual experience, actually.
But what about those cases in which individuals make wrong decisions?
Well, we all make very wrong decision often, but it's still very much about our body, and it's really important to be respected. For instance, people who follow certain religions, they would not like to have blood transfusion, and that's probably for many people it is a wrong decision. But that decision is very important for the individual. We cannot go over, and then probably that's I'm talking about something extreme.
Suzanne, you want to say something?
Yeah, I want to jump in here a little bit. I think the idea of an individual experience of birth in China is a relatively recent phenomenon. In other words, when I was doing research in the 90s in Beijing, women did not see this as an experience that they wanted to experience. They were going to have one child and they wanted to get through it. So there wasn't this idea that, you know, they should be in control and there's, you know, the medical authority is sort of long-standing, but I think that really it was interesting when I was interviewing them after the birth, they didn't even want to talk about it. It was something they endured to get through, and they knew they never had to do it again. So I think this idea of the individual experience as sort of something that matters to people I think it's changed a lot, but I think there's a longer tradition of it not being the most important part for people.
Can I just jump in quickly for Suzanne? Can you hear me? Sorry.
Yeah,
yes.
We can hear you.
Yeah. Just to actually supplement Suzanne's talk at your research done in the 1990s, the research I did together with Gonzalo, and I look at the urban part, women still today is very much like what you described. Again, I'm doing my research, talking to all these women giving birth in late 2000s and in early 2010s. And for them, that's exactly the same. They don't like to actually think about the whole process of making decisions as an empowering experience. I think there are a lot of, you know, the East Asians, I think it as a method is a very important point because it actually pushes us to think about individual women may not consider birthing experience the same way as many of the literatures suggest. And we need to really contextualize and try to really understand the way they understand birth in their own context. And in fact, when I talk to those women, exactly like what Suzanne's experience, they don't want to talk about it. So the question, I have to make so much effort to make them even try to talk about it at all. And sometimes I actually don't necessarily think that, you know, having to make have to make a decisions on behalf of themselves is actually empowering. And sometimes it seems to me there are occasions that they are quite happy that someone else is making the decisions because then they will not be blamed for whatever that happened. And I'm talking about women who are actually quite well educated. Every one of them have a college education.
So I just want to add one thing quickly, and that is I think where women actually think much more about the individualized experience is postpartum. That they want to manage that much more now, especially. So I think that's where we see that kind of empowerment happening. And one more thing, pregnancy books. For a long time, there was no section on birth, which literally there was very little written about birth, and maybe 2 or 3 pages in a popular pregnancy book.
Sorry to interject, but it's so interesting, and my question is related to the discussion just now. So for Suzanne and June, do you think it's related to the women's level of education and whether they're rural or urban? Or it's just more generally in China, pregnant people don't think about it that way?
I think it's general.
I think it's general too.
Totally general.
In my sample, it was pretty,
No doubt about it,
I mean, June, you were saying your sample is more educated women, is that right?
Yeah, they are professionals. We are talking about quite mid-rank government officials and lawyers, business women, and accountants, and you will, all of them fall comfortably into the middle class, educated class, and they basically, just like what you described.
Yeah. Ishan, I think there's a question for,
I'll just go one by one, and then I'll have most people covered. So I think Cho asked the question to Chiaki Shirai. So in your presentation, you said that C-section is considered shameful for Japanese mother. Also in South Korea, mothers who got cesarean might be blamed for their weakness, but the rate of cesarean section in Korea is quite high since doctors want their patient to give cesarean to derive benefit. Cesarean is more costly than vaginal birth. So this is my question. Don't Japanese doctors want their patients to get the cesarean delivery for their own benefit, safety, or whatever? I want to know if doctors could affect the decisions of mothers regarding delivery method.
.私の友達の小沢さんが翻訳してくれます。小沢さん、すみません、お願いします。一言。
そう、翻訳って今
なんか小沢さんがしますって言ってもいいですか？
Yes, I'm gonna interpret for Chiaki. So Chiaki is
Thank you.
はい。帝王切開は保険のシステムが日本にはとても大きく影響していて、まず女性自身が、帝王切開したいとか何日に産みたいということは全くできません。
In Japan, the national insurance, the health system affects this system, so it's not up to women to have cesarean section or not.
またさらに、妊婦自身が私が先ほど説明したように痛みを経験しなければ母にはなれない。今チピさんも参加してますけども、チピさんが論文で言ってるのは、腹を痛めた子っていう言い方がやはりあって、お腹を痛めて陣痛を経験して膣から産んで痛みを経験しないといい母にはなれないという規範もあって、妊婦自身も帝王切開をしてくださいとドクターに言うことも少ないし、ドクターがパターナリズムで、あなたは帝王切開ですっていうふうに言わないと、女性自ら帝王切開したいですっていうこともあまりないと思います。Oh, you're muted, Junko.
Junko, you have to be on mute.
Sorry, thank you. この質問は多分ね、女性が、どうしたいっていうよりは、医師が勝手に決めちゃうことってあるのかなって感じの質問だと思うんだけど、でもここまで訳すね。So in Japan, there is a strong idea that women should experience contraction pain, and then to have a child means you have vaginal birth after having contraction pain. That's a kind of 腹を痛めた子 means the child you bore, and that's one of the things that the Japanese women carries as being good mother. So for women to ask for cesarean section is still kind of contradict with the value of good mother. Now 教えてくれる？その後ごめんね。
なので、ドクターに自分から帝王切開してくださいということもないし、ドクターも医療保険が使える異常分娩じゃないと帝王切開できないから、帝王切開率は低くなる。それはでも結果的にいいことかもしれないけれどもっていうのも言ってください。
So that is not up to women, and also because of the insurance system, medical person has to operate when there is a necessity, and then so the cesarean section is not that manipulated, and then probably that contributes to the fairly low rate of cesarean section in Japan, and that probably is a positive side.
Okay, I'll just move on to the next question by, I think,
Chipi-san,
Chipi,
一言。
Chipi, you want to ask a question, jump into, yeah, okay.
Chiki-san.
Yeah, hello. Thank you so much. This was so fascinating. It was such fun to hear your three presentations. I wanted to ask many questions. First of all, I was wondering about the very recent discussion that was coming up here about pain as something that has to do with a good mother. And from my field work, it seems like not so much, but of course it's about being a good mother, but it's more about pain as being a mechanism for bonding with a child. I think I think that when doctors were trying to explain to me why they think that cesarean sections, unnecessary cesarean sections are so bad, and why Mutsu Bunben is so bad, they were trying to say that the bonding is damaged when the pain is gone. That's one thing that I was wondering about. But another thing that I wanted to ask Shirai Sensei, there are and everybody, freestyle bunben is a concept that I really searched for it in many. I searched for this concept outside of Japan, and I couldn't really find where they use freestyle bunben. And I'm wondering where this term came from. I'm really curious because the literature, the childbirth literature, speaks about the multiple meanings of natural birth, and as Gonzalo, I'm sorry, said before, a woman may give birth a vaginal birth, but with many interventions, and she might consider this as a natural birth. So the childbirth literature is really discusses quite much the difference between natural birth and vaginal birth and all these other meanings. But what's freestyle birth? And also, the second question is about Mutsu Bunben, which is also a concept that I couldn't find anywhere else but in Japan. Like in Israel, where I'm based, it's epidural. If you would translate this, it would be an epidural anesthesia birth. It won't be. Mutsu Bunben says something about the birth that other conceptions don't say. I hope I'm clarifying my question.
Maybe the better way we do it is that we go through the rest of the questions and then we have the speakers like freely answering to those questions in a freestyle way.
Okay, I think that's a good idea because there are lots of questions as well.
Yeah. So we have a question. Let me see. Yeah, I'm a bit lost.
Can I say something? Just a little thing.
Yeah.
About, I just wrote a paper, and it was published in 2019 about childbirth in the midst of March 11 disasters. And it turned out to be that the fact that Mutsu Bunben is so unpopular in Japan, and C-sections are so, doctors are so cautious about relatively cautious about unnecessary C-sections, this turned out to be quite positive in the midst of the disasters, because women could just, the midwives would disconnect them from the monitors and just help them go out of the building before everything collapses. So this turned out to be very positive. So
okay, we have a question asking about your opinions over the impact of the risk notion, governmentality, gender violence and that's on the health and maternal attention. So, and we have a question from Reijing asking first to Chiaki about the fetal abuse, because it sounds like the fetus is already taken as a person. So I wonder what is the personhood defined in Japan and how the notion shapes their treatment to the fetus. And further, how do they deal with the abnormalities found in the fetus? Do they recommend abortion or otherwise? Jinko, I think you have covered the question, so I would just hop to Regine has another comment. So I also noticed that both Gonzalo and Chiaki mentioned the natural body in China and Japan. I wonder if it means the same in these two countries. And then we have Loretta ask a question to Gonzalo and Suzanne if they have the chance to discuss this tragedy with their interlocutors in China. I'm not sure what that is, so maybe you could explain a little bit more. And for Shirai, the question is, can you say a little bit more about why the use of contraceptive pills and implants are so low? Then we have a question from Ying Wang. So I have a question to Chiaki Shirai. Pavlov's psychoprophylactic method was introduced in Japan in 1953 by Masatomo Sugai. Did it influence women in Japan from 1950s to 1960s? And we have a follow-up question from Loretta. So I'm wondering if the fact that Chinese women do not want to take ownership of the birth method is due to the lack of choices. So by choices, I mean women in China only asked to choose between natural and cesarean, whereas in the UK, for example, natural birth can happen in labor room, on hospital bed, and the pool, at home. So in the UK scenario, even when women who opt for natural births, there are still a lot of decisions for them to make. And yeah, I think Francesca asked a question. So it seems that in Japan, a gynocentric approach would involve only the pregnant woman, while in China it involves that woman within a group of related women. And Azumi says, Nakayama reported from her fieldwork related to giving birth in rural area in Japan. She pointed out a lot of factors, politics of medical authority and measure of government kind of policy of safety in 1950 to 1960, when the giving birth was medicalized and institutionalized in Japan. She also pointed out women made their decisions to give birth at birth center with a midwife because they could be released from their task at home as a wife and a mother. Because midwife is not only the professional of giving birth, but also supporting women's everyday living. After institutionalization, the main actor changed from midwife to gynecologist during 1950 to 1970. Yeah. So maybe I should say there's no much questions in the remaining, so I guess we could stop here and then have the answers and the comments from the speakers.
Chiaki-san, perhaps you start, then Suzanne, and then me.
Okay. Actually, I want to discuss a lot of things, but some points I will answer. 小沢さん、お願いします。一つ、やはりね、今日とても本当は議論したかったことは、ジェンダーということです。ジェンダー。今日トピックになかなか上がってこなかったけど、そのグッドマザーの背景にはやっぱりジェンダーっていうのがあって、でその一つに今日十分議論できなかった遠因切開の問題があると思います。
So there are lots of things Chiaki would like to discuss today, and one of them, she didn't have enough time, was gender. So this good mother role or view of the good mother, that's backed up by the gender role. And one of the things she wanted to discuss is episiotomy.
日本の産婆はとてもその遠因を 出産するときに栄養が切れないように栄養保護技術を磨いてきました。で、その栄養が切れないかどうかで産婆が評価されるほど栄養切開は栄養保護は産婆にとって重要なものでした。
So traditionally, the traditional midwife and also the current modern midwives, they develop their skill to protect the perineum very much. And then it used to be, or it's still, that the ability to protect women's perineum is kind of if that one is a good midwife, she can protect women's perineum.
で、今現在は栄養切開は日本でもたくさんされていて、特に1人目を出産するときには栄養切開というのがルーティンになっている病院、クリニックもまだたくさんあります。でもそこでもやっぱりジェンダーっていうのが働いていて、女性が受ける説明というのは避けるよりもきれいに切った方がきれいに縫合できるよと。でその背景にはやっぱり、夫が喜ぶ女性器、夫のための栄養切開っていうのがあって、栄養保護をするのも栄養切開をするのも両方ともそのジェンダー的に女性の身体が夫をきちんと喜ばすことができるっていうことが背景にあると思います。もちろん痛みに対する考えもあるけれども、もう一つそのジェンダーというポイントはとても大きいと思います。
So, currently in the obstetric-led unit, there are lots of episiotomy happening, and then the explanation women get is, so the cut is better than tear to repair, and then there is some thoughts behind it is that the good intact or good, same as midwives protecting perineum, having episiotomy is also to preserve the function of vagina as a sexual organ which satisfies husband's sexual desire. So there is something that, of course, there is something to do with pain for women, but there is a lot of consideration made for men. 大丈夫かな？
実ははい、ありがとう。もう一つ他にあった質問の避妊っていうのともこのジェンダーは大きく関わっていて、日本ではその注射とか、ピルが少ない、女性の身体に何かナチュラルボディを保たないようにするんじゃなくて男性がコンドームを使う。でもそれは本当男性に避妊をするかしないかの意思決定が委ねられる。で女性は基本的に男性が求めれば子供を産むべきというジェンダーがそのコントラセプションにも影響していると思います。
So this goes to the question about contraceptives. So in Japan, women to have pills or the implant or depot, actually implant is not allowed in Japan, so it's not considered as a good thing because it's not natural, and then the contraception is left to husband or man, because when so the control is on men's side. So when male partner would like to have a female partner to have a child, she should be accepting, she should be obeying, and then following the wish of the male part of the partnership.
ありがとう。最後に一つだけラマーズとか先ほどの1950年代の痛みのことがいわゆる、当時無痛分娩って言われたもの、精神性無痛分娩って言われたものについて一つコメントしたいんですけれども、実は私自身も14年間助産院で働いていましたし、私は助産院で出産して、自宅出産もした、私自身がナチュラルボディの規範の中にある人間ではあります。一つちょっと加えてください。
So this is the last thing she wanted to say. So she's worked in the birth center led by a midwife for 14 years, and then she's had a natural birth herself. So she is within this idea of normal natural birth context of, body herself.
ただ一つ日本でのその、長々続いているそのラマーズだったりとかっていうのもやっぱりメディカライズドナチュラルバース であって、例えばあなたは自宅出産していいですよとか、あなたは、健康な妊婦だから何々していいですよってメディカルチェックを受けて、で、じゃあ、破水してから24時間、48時間以内だったらいいですよって、時間も場所も決められる。で、この時間も場所もメディカライズドされてるというのはチピさんのアイデアなんだけども、だからそういうふうにメディカライズドされたナチュラルバースであるっていうことが言えると思います。
So the 1970s, there was this lamas, which was meant to be kind of mutsu bunben with psychological mutsu anesthetic.
Endless labor.
Yeah, and then that's it's still intervention. So within the context, medical, so the women are getting allowed. The women are allowed to have a normal birth because she's low risk, or she's she hasn't, her water hasn't gone for 24 hours. So she can go to the she can stay at home to have baby at home. So there is some idea of permission rather than her own. Well, is it like that, Shirai-san?
Yeah, thank you. Thank you so much. That's all. Thank you.
And then thanks for bearing with my interpreting. Thanks.
Well, thank you for interpreting, Suzanne.
So I thought I'd take up the questions or sort of observations about risk, governmentality, and gender violence. And I think that the notion of risk, at least, you know, when you look at these sort of policy level, and then you look at individuals. And the problem with risk, of course, is it's a population number. It does not help us actually understand what an individual's risks are for anything. But I think that it has become more important in general that, at least from my experience in China, that women are concerned about the risk to the fetus. Their own bodies are important, but the fetus is becoming it has become very important because it's, you know, been one child. So I think that's something that I think about a lot. The other thing I would say is I've come up with this idea of what I call maternal governance, and that sort of allows us to see how governance happens from the very, very multilateral institutions like the UN, UNICEF, WHO, down to hospital practices or clinic practices. So I think when we trace those kinds of shifts or policies or practices, I think there's a really interesting way of understanding how technology emerges to respond to what, you know, might be considered risky for the state versus risky for the mother. So these are some of the things I think that these kinds of framings help us see some of the connections between the macro and the micro.
I would like to take up the question, I think by Loretta, about a scandal, a tragedy that took place in Shanxi province in 2017. A girl called Ma Rongrong. She was in the process of labor, and due to a series of incidents, she ended up jumping from a 5th floor window and committed suicide. And of course, when this happened, was a big internet. There was a big internet roar around it, and lots of debates. Initially, everybody was blaming the family of Ma Rongrong because basically she had requested there is footage in which she's requesting for a C-section on her knees, and apparently the family has blocked the request and refused to sign the C-section consent form. And then eventually the accusations turned against the hospitals because of mismanagement and so on and so forth. And eventually it also became apparent that the hospital did not want to do a C-section because of new policies on C-section limits that have been enforced in Chinese hospitals starting from 2011 and 2012. And so anyway, so this is an example of how the system of these gynocentric networks of care involving hospitals can go really wrong, right? And in so many different ways. And also it reminds us to answer another question asked for Loretta, that women in China, even today in public hospitals, they are giving birth on her own. They cannot take, their partners, their mothers, their mothers-in-law. They are taken into the delivery room on her own. And it's certainly the case that, whatever happened to Ma Rongrong, it must have to do with the fact that she was just completely desperate, inside the maternity ward on her own, surrounded by doctors and nurses, and without having nobody to speak, and nobody was hearing her voice, basically. The upside of things is that, yes, for those who can afford to have the births they want, there are growing options in China. This is another question asked by Loretta. So yes, you can have all the options that you mentioned in your questions. Have give a birth inside a pool if you want to, and you can bring your own doula to the hospital. And but of course, that requires money. That's not the package that is on offer in most public hospitals. Thank you very much for your questions.
Okay, I think we have overrun for like 5 minutes, but I think since we have 3 speakers and we have so engaged audience today, it is already quite on time, and I think everybody quite enjoyed it. So let's thank the 3 speakers again for coming and giving this such a interesting and profound talk. And thank you everyone for coming and staying with us.
Thank you, Yi-chan, for sharing.
Thank you very much.
Bye-bye.
Bye-bye.
Bye.